I'm a PhD in digital health candidate at the Melbourne School of Computing and Information Systems and a research fellow in regulation and design at the Melbourne School of Government, doing lots of research around digital health in mental health contexts, but also designing for culturally and linguistically diverse communities who also have experiences of disability. And that's what I'm talking about later today.
Fantastic, fantastic. We're looking forward to that. Okay, so we really had two unfortunate cases, just to sort of put context in why this panel discussion was sort of impromptu. Unfortunately, due to the situation at this moment, two of our speakers couldn't make it. But we'd love to actually be talking about accessibility and just accessibility within healthcare. How are we designing for that? Has the pandemic changed the way we communicate with our users? And just demystifying a little bit about that. So, I mean, just to start it off, if with yourself, Chris, I'm just going to ask, what's your take on it with regards to designing for healthcare, and then I'll move on to Timothy.
So maybe just a little bit of general stuff, and then maybe a bit about COVID impacts. Is that right, Theo? Yeah. I'll go ahead. You're not saying no. Okay. So, in a nutshell, in theory, there's lots to think about with regard to digital health, that it will increase accessibility in theory. But there's a real challenge, I think, in bringing that theory to life, seeing it was actually true. I think we're still in a phase where that's the case. There's no question that we run the risk of having maybe a different kind of divide to what we do now, or a twist on the divide we have now, where some people who don't have access to the right technology or aren't, have a natural affinity with technology are disadvantaged. And I think we need to be really careful about that. And there's all sorts of people working in that space, and it's good and it's important they do. I think there's some interesting things about COVID, certainly from Australia. Again, it might differ with different members of the audience, but it seems really clear that even though we've got this notion that telehealth has gone on steroids in our country, and again, it varies a little with the specific context, but in fact, what seems to be happening is, yes, there's many, many more telehealth consultations, but in many cases, they're basically phone calls. There's lots of data in our country saying that really people are just using the phone. And anyone who's treated a patient knows that inherently there's a limitation there. So I still think, I'm hoping out the other side of the pandemic, we end up with a somewhat transformed healthcare system for the better, but we also start to address the fact that telehealth can do a lot more than just a phone call already. And hopefully we can see some of that come to life again in a safe way that hopefully includes more people than it excludes.
Thanks, Chris, for that introduction. And let me start by just acknowledging that I'm here on Wurundjeri land of the Kulin Nations, and pay my respects to elders past and present. I guess thinking about coronavirus or COVID-19 and the impacts it's had on, I guess, our thinking about accessibility, something which I will talk about later, so I'll try not to repeat myself too much from my presentation this afternoon, is that it's really changed how we think about choice of how we access services. So historically, and I'll use the example of government services or essential services like power and water, and I will bring it back to health in a moment. You could access it online or you could access it in person. And the online services were really designed for the majority, not really for marginalized populations. Now that choice has been consolidated into you access it online because you can't go out of your house in most cases. And a lot of organizations are probably realizing that actually the online is probably a lot cheaper. And some organizations have probably got rid of their face-to-face presence. Now, this is different in healthcare for obvious reasons, but as Chris has alluded to, we have seen a huge rise in telehealth. And in some ways, it's become the norm. And I don't think that will change post-COVID. I think the funding structures will change, but I think that Australians will expect that it is an option that they have access to, be that under Medicare or not under Medicare. And we need to realize that telehealth has been available pre-COVID. It's just that the Medicare funding was obviously a lot more restricted. But I guess the question this raises is, how do we make sure that all of these digital applications, if they are the norm or equal to the norm, how are they accessible to all people? Chris mentioned, most of telehealth in the COVID situation is via phone, which is very different to pre-COVID, where much of that was via outpatient. So you would still go to your local GP clinic and maybe telehealth with a specialist. And I think that the phone is one option, video is one option, but then I think we've actually got to start to think about what are the 101 other options? How can we use gamification? How can we use different elements of the screen for people who might not find screen-based activities or seeing themselves on the screen as an option? How can we provide care to people who have low data plans or who don't even have computers and only have smartphones? So for me, I think accessibility is a question of how do we personalize care? How do we move from this idea of personalized medicine to personalized models of care? And I would argue that I would say that we are really bad at doing models of care for digital. We kind of just plop digital into existing models of care and hope that they will adapt. But I think in terms of accessibility, we need to start thinking, how can we have a suite, a toolbox of models of care which are enabled or have the option of digital that can be personalized? And then the big question, and this is a funding question, how do we give clinicians the time to actually know their patients and their service users to work out what model of care and what digital technologies meet their needs? And I think that's, for all things, pre-COVID, post-COVID, where we've probably fallen down, that the government just doesn't fund our clinicians enough to do that work that needs to be done.
Sorry, I'm toggling between mute and unmute. I'm really sorry about this. So,
if you don't like what we're saying, Theo, you can just tell us live. It's all good. You don't need to matter.
Not that at all. In fact, I think we could probably go on for days about this. I think both of you have touched on fantastic points, which I just want to touch on briefly. And there's about 5 points I've mentioned here, especially when it comes to accessibility. And really, I just want to start with clinicians. I don't think it's an Australian problem. I think it's a global problem with regards to that. We're expecting more from clinicians and having to deal with patients. So just touching back onto the point that you've made as well, Timothy, how do you think, take into existence what clinicians' workloads at the moment, and then still having to deal with accessibility, the EHR sector of it? How are we going to sort of navigate? I know it's a very broad question, but from a very clinician's perspective, how do you think we're going to navigate around that and being able to, for a better word, add to the workload of telehealth?
Yeah, well, look, I'll answer, and I'll probably say something controversial, and then I'll let Chris maybe come back with some less controversial. Look, I think we need to recenter the conversation away from clinicians. I think clinicians get talked about way too much. A lot of the work done in the healthcare system is by patients. To be honest, they do a lot of the work filling gaps. But I think what is a more beneficial discussion to have is it clinicians who should be doing this work in the first place? I would argue no. I think there's a huge gap in our healthcare system between the service user and the clinical systems in terms of community health, where we could have less intensely trained people providing that coordinating ability. So that could be peer workers, that could be healthcare navigators. In the mental health setting, which is my interest, that could be people providing low intensity therapies. And I actually think that we need to start discussing models of care which make those people central and make digital central to that. I don't see why we can't have a set of qualified, low qualifications, but still qualified citizens using WhatsApp. Most people use WhatsApp, most young people especially use WhatsApp, providing low intensity mental health treatment. Because I think the issue is that we've got a lot of people who don't really need to be seeing their GP, don't really need to be seeing a psychologist or psychiatrist, who are clogging up the system because we just don't have anyone else. In the UK, we've got step model of care, which I think is a good stepping stone. I don't think it's perfect. I think it has to be contextualized to local communities, which I think is challenging when we're talking about models of care. It's too easy just to come up with one, such as healthcare homes, roll it out, work out that it doesn't work, and then go, too hard. So I think in answer to your question, I think it's not about clinicians. I think we know what clinicians should do. We're just expecting them to do much more than that. And I think we need to take all of that work that clinicians don't need to do and put it on someone else, and also take some of the work that patients are doing in terms of navigating the healthcare system and put that on someone else. We know that healthcare navigators work. We just need to fund them, and we need to make sure that they're part of a proven model of care. I don't know if Chris can maybe add some more to that, or I don't know, critique that statement.
No, there's lots that Tim said that I completely agree with. I put a slight twist on it. I think, it's the nature of the true digital health conversation that patients are more empowered as part of that. That's one of our outcomes, one of the things we want. So I'm not detracting from that, but I think there's a subtle difference. It shouldn't be about clinicians, and I use that term broadly, but it still is. Yeah. And in getting to those outcomes, if we don't find ways to engage clinicians in that as a mass, as a group, they're perfectly capable of obstructing that change in all sorts of ways. So we need to sort of do that with them as part of it, and that's not an easy thing to do. I suppose I'd throw something in there as an exemplar, right? So, there's a whole incentivization conversation. So we've had more telehealth funded through COVID, so more is being done, funnily enough, plus through just practical necessity. If I reflect on, and I mentioned this in my earlier talk, a trip to HIMSS, at that point I was told by people there that their federal government had just announced rebates for doctors in the virtual care setting. So chronic disease monitoring, they got paid for something like an hour per month just to review the patient's data. Not to see the patient, just to review the patient's data. So I will make time for you to work with this model and you will be paid for it, which is one of the unfortunate sort of practical realities we still face. I've used this example a few times too. So, I don't mean to be medically centric. That's my background, so it tends to be a bit that way. So if you contemplate a family physician or a GP in Australia, in the current decision-making model, they will examine a patient, do what's best for the patient, do their absolute best, and maybe, say, give them a medicine. Okay. If you think of it this way, imagine if every time a doctor had to make some intervention, including the prescription of a medicine, they had to swallow 1/10 of the dose. So suddenly they're bought into that intervention. That intervention touches them in a personal way. It's a bit like that with some of these telehealth things, right? Or some of these digital health things. So we look at, say, Propeller Health, which I won't go into unless people ask, or Cardia. As standalone digital tools or interventions, there's an enormous evidence base saying they're really good. But why would a doctor use one when they're not paid to do so, not given time to do so? So the impact on them of using those interventions is too overwhelming with the current structures and incentives. Hope that gives you a sense of where I sit on all that.
Thank you for that. I just have a question here from, the question was, what are some better ways to conduct user accessibility testing during COVID for mobile apps, especially for older users who are more risk adverse or who are more at risk? So, Chris, I'll give it to you.
I don't have a magic answer for that. The ones that you could sort of mock something up remotely, they're probably the ones you least need to do it with. It's really the ones who aren't comfortable maybe with using a computer, for instance, but then you've got to see them face to face. So there's no magic answer. From where I sit, I think the barriers of COVID, Tim might have thoughts about how to get around some of that.
No magic answer on this side of the screen either, Chris, but I think I think all of us have to re-evaluate our metrics of success when doing usability testing at this time. So you are not going to be able to do your gold standard, but I think it opens up opportunities for creativity. I've seen some really interesting projects where people have sent out little gift boxes to people's homes with things that they can do their usability testing in their lounge rooms and as a kind of creative hobby type of thing. So I think Yeah, I think throwing out the traditional metrics of success and being creative and using COVID as an excuse to be creative and to kind of, I think, break away from some of these very positivist or very kind of let's measure this, say that this is a number that we can point at of success, and actually start to hear people's stories and opinions of working with some of our methods and tools. So I would say, don't be scared of being creative and just using COVID as an excuse if it all falls apart.
Are you suggesting throwing the gold standard of measuring your usability just out of the window and having to rethink that model?
I don't think you should throw it out the window. I just think I'm not a big fan of gold standards in general, unless they're life or death gold standards. I don't think, unless you're like, I think a gold standard in this type of work has been decided by someone, right? Someone just decided one day this is a gold standard. So I don't think there is a gold standard in UX design, in my opinion. I think the gold standard is what we decide, and we might have a different gold standard in COVID, and then that might change our perception of what gold standard usability testing is after COVID. Yeah. Okay.
And for yourself, though, Chris, I don't know if you'd be able to answer this one. I know you spoke about telehealth. Globally, I think we're battling with that, even more so in our third world countries where telehealth is. And I just had an appointment a couple of weeks ago with my doctor, and we were just talking about how she's navigating telehealth, and she has a form she sends out to patients before she actually schedules about 10-15 minutes of a time to interview them.
Yes.
So with regards to telehealth, and accessibilities and rural areas where they don't have access to video conferencing or smartphones. I mean, how are you having to rethink that, for example?
I mean, I'm not in the field anymore, but I think Tim's spirit of do the best you can safely is not a bad one at the minute. It's better you have some contact with a healthcare practitioner of some description about an issue than avoiding it. And we actually have seen data about this start to come out now. People's behaviours have changed when it comes to access to healthcare in both elective and, semi-urgent settings. And we're seeing the impacts of those now, certainly from data in our country. So it's much better that someone, have a phone call, because that's all they can do, than worry about having, co-view or attend anywhere or something and not having access to it. Because it has to be this spirit of let's just safely try and do what we can.
So true.
But I think maybe one of the things you're picking up, Theo, too, is, this sense of working with patients and consumers around their comfort and how these things actually work. And it's good to hear, someone you've described might actually preemptively send out either some instructions or a questionnaire to sort of then lead into the interaction. That kind of stuff I think is quite important, is my sense. And I sort of anecdotally hear people who are still working in hospitals have come up with those sort of workflows because they've done more telehealth far more than they've ever done before. They start to bubble some of these sort of unforeseen problems up, and hence they get better at doing it as well, which makes sense.
My biggest concern with telehealth is that, from an insurance background, is that something that is covered? Is that something that's thought about within the insurance sector? Is the insurance sector changing their language with regards to, COVID-19 now? That's really my biggest concern. And also, who's liable if something goes wrong? Is there a disclaimer from the clinician side? I mean, surely there has to be a disclaimer, in my opinion.
I might just comment on that, because we've done a lot of work of late, which we're going to continue, about a concept of enhanced telehealth. So think of it as, what else can you do in a consultation setting like this, aside from look at someone and speak to them? And so the underlying technology standard that some of the companies use, which is an open standard, for example, also has a data channel. So if I could watch your heart rate tracing now while you tell me you do or don't have chest pain, or you are or aren't out of breath, that's another step up beyond just this, right? If you add to that things like digital stethoscopes that start to automatically detect heart sounds and murmurs and can distinguish certain kinds of crepitations in the lung. There's papers around that. There's some products on the market. That's all coming. It's here. It's coming, you know. So for the insurers of the world and the governance organisations around healthcare, they got some really big questions to start asking themselves, sort of like what you posed. What becomes the new standard of care when you've just flipped it all on its head, right? And then who is liable, and where does the developer of the system fit in this? And if there's AI, who's liable for that? It starts to get really complex. Don't have the magic answer, but if the insurers and the funders and the governors of healthcare around the world aren't starting to grapple with that, then they're probably a bit too late already, I would have thought.
Okay. Do you have anything to add to that, though, Tim?
No, I think the only thing I would add is that a lot of these discussions about insurance are obviously specific to different jurisdictions, and I think that is a challenge when we think about a lot of our digital health technologies are emerging out of places like North America, which have a different healthcare system, and how do we translate not just the insurance, but also the usability of that to the Australian system. And I think we can't underestimate how much the health system and policies influence how things are designed, and even very small design decisions, and then how that's translated across global jurisdictions.
Okay.
I get there's an interesting follow-on anecdote, hopefully for people off what Tim's saying, that's absolutely true. But the other thing that's happening is digital health is ignoring all those rules. It has no jurisdiction. So, you know, I'm not sure if people on the call have heard of a thing called Empatica. So it's a wearable watch type device that can detect imminent seizures in epileptics. And like a lot of these things in the States, it's a product. There's a thing in the top right of the website, buy now, right? And I've seen products purchased by Australians, because they come and tell me after I give a talk, that aren't actually, you don't go to the chemist here, you order them online, right? When it comes to Empatica, this is a couple of years ago, I have lots of social media accounts for work, but I have a private Facebook account that's just for friends. And I do stupid pictures and stuff. I don't do anything work on it. But one day I had Empatica push marketed to me on my private Facebook account, which on one hand shouldn't surprise us, from the US. So if I can buy it, but I probably could have, jurisdiction, what does that mean? I turn up to my GP with it and the readout from the app. Jurisdiction means nothing, right? So that's coming with some of this, whether we want it to or not, it's just happening. So I think that's the other extra layer of challenge in all this. Just as we've seen with the tech giants, right? You know, it's only now some governments going, oh, actually, we don't want that big American company doing stuff in Australia. We better make some laws. It's going to be the same thing with some of these digital health technology.
Absolutely. Okay. And just with regards to, I see there's another question that popped up. I just had one question from my side. When it comes to accessibility and having to analyze data, are we changing that model? I'm assuming everyone's working remote at this moment in time. Do we, from a user research, remote, does it change how you analyze your data because it's not one-on-one anymore? What is your thought on that? I mean, I don't know if it's a valid question.
I've done a lot of my research remote just because I work with a lot of populations in vulnerable context who I find that they actually prefer a phone call, and user ethics prefers a phone call because you reduce the risk. And I think what I value a lot more about that is it's a bit of motivation to validate. I think sometimes when you do a face-to-face interview and you've seen the person, you've seen the body language, you think you've got it all. When you've got a phone-to-phone interview, I think it makes you a lot more uncertain and you're motivated to go back and check with that person. So a lot of the work I'm doing right now is going back to talk to people I interviewed a while ago and say, hey, I've been really thinking about this. Is this what you meant? And like that's good research practice from an academic point of view. But I think sometimes in usability, we talk to someone and then we might just go, oh, yeah, that's done, move on to the next person. And I think that from my perspective, doing it virtually might just add that bit of uncertainty that motivates us to maybe go back and check in with people. I also think that it reduces, how do I say this, like doing things remotely I guess, gets rid of our excuses not to involve other people in our data analysis. Like when we're locked away in our office, it can sometimes be like, yes, we're here. I own this data. I'm the only one who can see it. But I think we need to ask, why can't we bring our participants up on Zoom to look at the data with us and go, how would you interpret this? What does this mean to you? And the idea of co-design right throughout the process. A lot of the times co-design can stop at the data analysis because it's on a computer in an office somewhere, or because we do view it as too complex. I think working from home and breaking down that boundary could potentially be a good thing for that. Obviously, taking privacy and confidentiality into consideration.
Okay, thank you. So one question that's popped up here, with mental health being a risk issue now, how do we design non-intrusive experiences that can drive more engagement without turning a patient off using the platform? So anyone of you guys can answer that.
It sounds more a Tim thing. Sorry.
Look, thanks, Chris, for volleying that back over the net. Look, I think I'd challenge the word risk right away. The mental health challenges we are seeing are a very reasonable response to a global pandemic. And I think that, first let's differentiate between our more common mental health concerns, experiences of depression and anxiety, which are very relevant emotional responses to this current situation, and then our more complex mental health conditions, which can be experiences of trauma, severe trauma and distress. So on our depression and anxiety side, our very appropriate emotional reflections on the current situation, I think from a design perspective, it's about having empathy and about thinking about the type of information you're providing. I remember one participant I interviewed said, sometimes just a bit of white space on the page is thinking space. It's emotional space. It's space to step back and just go, what the heck is going on? In terms of digital health and providing digital health technologies for complex chronic mental health conditions, I think the big challenge is acknowledging that a lot of people in that situation, in that side of the equation, also are experiencing a lot of social and economic vulnerability. And if we're designing digital health tools for that people, I think we need to recognize that their priorities might be housing, food, shelter, safety, might not be actually accessing a healthcare service. And how do we, if we're opposed to designing that, how do we show empathy in understanding that, I'm creating this tool for you and I acknowledge that it's probably not your number one priority. So I think empathy is the key thing, and acknowledging that all of these mental health responses are very appropriate responses to the current situation we're in. I feel depressed most days. I think many of us on the call have probably felt depressed over or anxious over the last several months. So drawing on those experiences in our design and not being scared to speak about them, I think that's what's important.
Thank you. Very good answer. Do you guys have any tips? I think we said we were going to do it for about 30 minutes and we're about 2 minutes in. So just to wrap up, I know you guys are already finished. I just want to ask just a top tip from each of you. Top tip for just remote sessions, running remote sessions in your finding and your journey. What would you think would be a top tip? Chris, I'll give it to you.
Okay. Are you meaning in the sense of, usability and user experience work, Theo?
Yeah.
Is that what you mean? Yeah. Okay.
Yeah, definitely.
Look, I'm not actively doing a lot of it. It's the nature of my job, which tends to be more supporting other researchers than doing research myself. Look, I think maybe it's just very clear expectations. So, this is what we're planning to do in this session. Is that okay with you? And also, it's partly personal style, an informality, relative informality, depends a bit on the exact setting, but keeping things fairly relaxed.
On my side of the equation, I think just giving people as much, look, it's a challenge, giving people as much information as possible and giving people time, but also not being overwhelming. So at the moment, I'm about to start a project where I'm just sending people some questions, really, some vignettes and some questions, and saying, if you could get these back to me in the next 2 months, that'd be great. I'm going to check in with you, see how your emotional state is. Yes. But, no pressure. So I think time and information is key. I think the other thing is that it's more work on our part. I think we need to be a lot more engaged in understanding the context of those we're talking to and personalizing our approach to research. Like over the last few months, and I'll talk about this later when I'm presenting with Zeng in the afternoon session, we're talking about we do focus groups, do interviews, and we're like, let's just put it all in the ethics application and just see what people want to do. Because right now, everyone's going to be in such unique situations. They're going to probably have family at home, maybe. They're going to be maybe living in situations where it's not easy to do a Zoom call. Maybe it's better to have a lot of data. Maybe they live in I've been teaching last semester with some students who are in very precarious family situations. So how can I provide them with every potential option within my power and then give them choice and space to make those decisions for themselves so that, I'm supporting them and I'm getting the outcome I need as well.
That's excellent. Thank you so much, guys. Really appreciate your time. Very insightful. I think for me, the biggest takeaway would really just be that, the communication with your users. I'm thinking that obviously pre and post COVID is going to have to change in a massive way, and how you navigate their system. I think this is part and parcel of why we have the UX community, and I know the digital health community in Australia is huge, and you've guys got so much resources you can tap into. But being able to just speak to people with regards to how do we, change our communication, because communication is going to have to change, and that's my biggest takeaway. So. Thank you so much, guys. Thank you.
Thanks, everyone. Thank you.
Thanks, everyone.